Dr. Nicholas Moss is the acting director of the Division of Communicable Disease Control and Prevention at the Alameda County Public Health Department, a role he took on in February of 2020. He served in the county's COVID-19 response since it started. Overseeing various aspects of the work, Dr. Moss is an infectious disease medicine specialist and medical epidemiologist by training. He first joined the department as the HIV/STD section in 2013, and prior to that, he worked on HIV prevention programs at the San Francisco Department of Public Health. Dr. Moss was born in the Bay Area and is a graduate of UC Berkeley. Go Bears.
Go Bears.
He received his medical degree from the University of California, Irvine, and trained in internal and infectious disease medicine and public health at the University of Washington in Seattle. Thank you so much for joining us tonight, Dr. Moss. And with that, I'll go ahead and pass it over to you.
Great, thank you, Dan. And I hope, can everybody hear me okay? Great, okay. I apologize for all the shadows. My Zoom game isn't great, even though my life is conference, Teams meetings and Zoom meetings these days. And so as you may have heard, I took over my current position at the beginning of February, which is, if you weren't reading the news, right around the time when COVID started heating up around the world. And it's been quite a, I don't even know how to encapsulate what it's been for us at the health department, but it has been a huge challenge. And I think it's also, a real call for us to try to do what we do best and serve the community. So I'm honored to be here to be able to share a little bit about contact tracing and maybe answer some questions about that and other aspects of our response, if that's helpful. And hopefully it'll be a useful discussion. I do have some slides. If it gets a little too slidey, maybe I'll try to break and we can have questions as we go. They're not my slides, so if I fumble over a few of them, please bear with me. They were somebody helped me prepare and then said she wasn't going to join tonight, so left me on my own. Okay, so this is our dashboard. It's at the acphd.org website. For anybody who's interested in looking at the numbers for Alameda County, we do have a little box for Berkeley there as well. I encourage taking a look at this. Most of the local health jurisdictions in California are doing these. This is our cumulative case count, total number of cases we've had in Alameda County, 3,841. This passed a very unfortunate milestone, 100 deaths locally in Alameda County. For those of you that follow the news, we, in the Bay Area region, we have the most cases. We had a substantial increase in recent weeks of eclipsing Santa Clara, which is actually a bigger county by not quite double our size. I think there's a couple things going on with this increase. Some of it is probably from increased mixing as some of these social distancing measures have been relaxed and as people have sort of also just started to try to get out and about more, and some people have returned to work, and then also from increased testing. So some of this is case detection, and we follow our hospitalizations as well to try to get a sense of how much severe disease we have. That's a little more maybe reliable indicator of what's going on. So our response, there's several different elements to it. The most, I think, notable, newsworthy, the most disruptive to everyone's lives, and also what has maybe been very effective in slowing things down in Alameda County, it seems, has been our shelter-in-place measures. The physical distancing, the face mask as part of that, but really, people staying home, not interacting as much. And but it's a very drastic step, and we do want to support, people returning to something like normal life, and in particular for, businesses, people need to get back to work, people need to support their families, People need to be able to go out to grocery stores, but also I think just the psychological health of the community, being able to mix again and get out and about. So we can't stay in shelter in place forever, and we need to rely on some other measures to try to identify where COVID is in Alameda County and try to limit its spread through other means. So that's where contact tracing comes in. And so that's been a big part of our response to date and will continue to be, as well as testing to support testing so cases can be detected. When we find cases, we isolate them. So we work with people who have COVID to make sure that they stay home for 10 days until they're better. We also look for their close contacts. That's the contact and contact tracing. And usually that's people in the household or other people that they spent a lot of face-to-face time with. And we want those people to be in quarantine. So that means staying home, but in this case for 14 days, in case they get sick. As many people may now know, when you start to get sick with COVID, you might not show symptoms and you might still be able to pass it to other people. So quarantine is really important to limit that spread. We also do a lot of work on outbreak response, particularly in people congregate living settings, nursing facilities, healthcare facilities, things like that. There's some of this makes the news. Sometimes we're not portrayed in the most favorable light, but believe me, we have a lot of staff working really hard to try to limit the impact of COVID in some, close settings where people just have to be near other people. We do a lot of health system support planning, helping make sure hospitals have plans in case we get very large numbers of cases, sort of like what's been seen in New York, where all of a sudden hospitals may have more people who need a bed than they have rooms at the inn. And of course, making sure that there's enough of a supply of personal protective equipment, in particular for healthcare workers and for first responders and then other settings as much as possible. Community engagement is very important. I think that's what we're doing today. But also partnership, it's not just the health department or county departments, it's working with a range of different partners across the county to try to, meet our goals. And we do a lot of work on sharing information. Our website, not the best, but much improved. A lot of information is in there if you can navigate it. And of course, there's other places where COVID information is available and shared. So contact tracing basics. This is like fundamental core building block public health. Health departments were built on contact tracing activities for things like tuberculosis and syphilis, diseases that are still with us, but we maybe don't think about as much. And we do it for other things as well. When you hear about measles cases in Alameda County or maybe a meningitis outbreak, we're working to find out who's been exposed, to find out who's sick, and to try to interrupt chains of transmission of disease. And so this is a big part of COVID. In Alameda County, we have been doing contact tracing since the very beginning, right? So we even before there were cases, we were concerned about suspect cases. We were interviewing travelers. We were working with hospitals to identify sick people who look like they might have COVID. We started that with our regular core team of like 7 staff who do this for over 80 reportable diseases. We have separate teams for HIV and STDs and tuberculosis, but most diseases of public health interest get reported to the same group of 7 people. And so what happens is somebody gets diagnosed with COVID by a medical provider, they get a lab test. Those are reported to us at the health department by law. That's how we know that somebody has COVID. They don't get tested, they never see a doctor. We're not necessarily going to know, and we can't do contact tracing. So testing is important. We want people to stay home when they're sick, but we do want to, ideally find out who's got COVID in Alameda County so we can do contact tracing. And we follow up with that person who's been diagnosed with COVID to make sure that they stay at home. We also are doing our best to, it's a big burden for people. And when you're talking about many people in the setting of these shelter-in-place rules and economic disruptions, it's a real challenge for people to stay home for 10 days, especially if they're a working adult in the family. Or it may just be that they need food delivered because now they can't go to the grocery store and they don't have anybody to get food to them. So we do try to connect people to resources, and this is an area we're trying to improve because it's such a big part of making this a success. So we work with people who are cases to safely isolate, usually at home, sometimes in other settings. And we also want to find out who their close contacts are. A rule of thumb is within 6 feet for, now it's more than 15 minutes. These are, imperfect, but we follow national guidelines there. So those are the close contacts. And we want those people to quarantine at home for 2 weeks for the reasons I shared earlier. So contact tracing is that process, finding the case, investigating them, finding out who the close contacts are, helping them quarantine, if possible, following them throughout their quarantine to see if they get sick, and ideally testing at least the symptomatic persons. We're not doing this yet, but maybe someday testing all close contacts for COVID-19. And so that's kind of the basic process. I'll pause there. Maybe if there are any questions for this first part of the talk, we could spend some time on those.
Sure, and I'll actually pass that over to Jolene. We had a few RSVP questions that came in, and so I think a couple of those have direct relationship here.
Right. So you did mention the Alameda County Health Department's website, but I don't know what the URL is. So if you wouldn't mind telling everybody that.
acphd.org. It's acphd.org, and there's a big COVID button on it, and you click that, and there's a bunch of stuff, including links to our dashboard.
Okay, perfect. We actually, most of the questions that we got ahead of time had to do with, can Alameda County residents volunteer to help or sign up or get trained in order to, I know there are culturally appropriate ways to do the work that you're talking about. And so can they do that? There's even someone here who mentioned that they had already filled out an application but hadn't heard back and they didn't know what they should do.
Well, maybe we'll save that discussion for a little later on. I know there's a lot of interest in how we're expanding contact tracing, and I know we've certainly heard from a lot of places about interest in volunteering. Let's see, maybe we would, I think we'll have a chance to talk about that a little bit later on. So maybe I'll just keep going.
Okay.
So now I have to do this the right way, which is to...
While you're doing that, you might know the answer to this one off the top of your head, but you mentioned that Alameda County has, as a leader in the Bay Area, but how does that compare to other areas in the Bay Area in general?
Yeah, so in terms of number of cases, we have the highest number. You also have to factor in the size of the county, and to really do it right, and we haven't been able to do this, you need to factor in sort of the demographics, the relative age. As much as we, Alameda or Bay Area counties are similar, they're not all the same. And there's differences in terms of, who lives there, who what their economic status is, how mobile they've been during shelter in place. But all that's, still, I think, we have to acknowledge in Alameda County, we continue to have transmission here, and we would like to contain it. We don't want to be number one. It's nothing to be proud about. But I think it reflects a lot of different dimensions to the outbreak. And there is a lot of information available at other counties' websites, and also State of California or the San Francisco Chronicle has a free COVID tracker, which tracks all the Bay Area numbers. So that's a good place for people to look if they want to see how we compare. So, there was questions about volunteering, how to get involved. So I mentioned that team of 7 people. We actually have, it says 75 here. I think we're in the 80s now in terms of the number of staff doing all aspects of case investigation and contact tracing, including some staff who work on like special settings, Santa Rita Jail, long-term care facilities, nursing homes. And so we've expanded a huge amount. We were adding staff at a rate of about 5 per week. But we're kind of at an inflection point. You know, as case numbers have climbed, getting about 70 cases reported to us a day. We need a lot of staff to process those cases. And if 70 cases, we're seeing about 4 close contacts per case. So that's, what is that, almost 300 contacts per day being identified. But once shelter in place relaxes further, it could be as many as 10. So that 70 means 700 contacts. And if 70 becomes 150, which we think could happen at a sort of a peak or surge, then you know, we're talking about thousands of contacts. So we need to get bigger. And there's a few different, you know, calculators and estimators out there. We've used some different tools, but we're targeting a goal of 300 people doing case investigation and contact tracing work, including some ancillary support staff. You know, so it's not just a contact tracing staff, but it's the managers, it's the training, it's maybe clinical support that needs to be expanded along with it. And in terms of time frame, we're planning for around 1.5 to 2 years. A lot of uncertainty. We don't know how long it'll take before there's a vaccine. We don't know how many members of the general public are really susceptible. But we're planning for COVID to be with us for some time. And then the other dimension of this is things change over time. With shelter in place, we saw a pause in our growth of cases. Now they're starting to go up. We may see a large increase later in the year. A lot of these mathematical models suggest that we could see a big increase in the fall or maybe late summer. And so we need to be a little bit flexible with our contact tracing. And so we really want a scalable model. So we're talking about lots of little teams, 8 to 10 people, and we can add teams or close teams down depending on what's going on with the epidemic. And in a way, the model for that is that original 7 people that I talked about who do all aspects of contact tracing during normal times. Don't pay too much attention to the details of this slide, because I think that we're actually probably going to have, yes, some county teams, but teams that are mixed with county folks, people with a lot of experience with disease control activities, and then people who are newly trained. There's just, you know, freshly joining the effort to become contact tracers, and we'll probably have combined teams. And we may have teams that are tied to specific partner organizations in the communities. We're already trying to pilot that because, you know, not everybody in Alameda County wants to get a call from me or somebody at the public health department. They're not so comfortable sharing their personal, you know, medical history with us. There may be language barriers or other cultural barriers. So we really want to work with organizations that are embedded in some of our communities most impacted. And we can talk a little bit more about who those are. But I don't think the public health department is always the best at all things. And so we really want to partner with people who can help us reach people and build trust. Because to do contact tracing right, you have to build trust. And we'll continue to have specialized teams that focus on these sort of complicated congregate residential settings. So again, probably a multidisciplinary team where there's some clinical expertise, there's some administrative leadership, and then mostly people whose job it is to just work their way through the cases, find out who the contacts are, contact those contacts, for lack of a better term. A lot of times it's household members, so if you reach a case, you're reaching the contacts. Sometimes it's close friends, sometimes it's coworkers, but it's not usually like somebody you rode the BART with, because often those interactions are transient. You don't know who that person is anyways. So really the contact tracing tends to be focused on people that the case, the person with COVID really knows from their life. And so having one team own that whole investigation is helpful because they can share information about how it's impacting, say, a household. And then we want for some of the reasons I brought up before, the way COVID is impacting certain communities differently, particularly Latinx communities and essential workers, people who haven't been able to sort of stay home and work from home during the epidemic so far. Also, African Americans, we're seeing disproportionate health impacts in that community in Alameda County. And there are some communities that have where there are language issues and cultural issues where we can't just use a phone interpreter. We need to do more in order to build trust. And so we want to approach all of this work with a health equity framework and actually have staff on each team whose job it is to kind of hold the rest of the team accountable to some of the health equity issues that we see. Because the fact is that COVID is just not impacting everybody equally. And I started talking about this. We actually have a health equity team already in our COVID response. I mentioned some of the communities impacted, African American, Latinx communities, also Pacific Islanders disproportionately impacted. You can see here, this map is, I'm not sure if it was pulled today, but the message is pretty consistent that this sort of 880 corridor is where we see the greatest amount of cases. That's where people are living in rather dense areas, and also maybe multiple families living in a single dwelling unit, single home, those kinds of things. And so we really are trying to apply all of our planning and all of our response activities. We're trying to apply this health equity frame. So timeline, we are at this inflection point now, as I mentioned. We're just starting to pilot this team structure where we train people on a brand new state software platform. The state contracted with Salesforce and Accenture to develop and roll out a software platform that counties across the state could use to do their contact tracing investigations. And they're building it now. We're piloting, giving them feedback. We have a weird sort of combination of different data platforms, some state platform, a homemade database, and then some paper-based stuff still. Yes, public health department still has paper-based systems. And so this is going to replace a lot of that, and I think it'll also be really helpful for looking at how good a job that we're doing. It'll also bring a lot of headaches. So we're training people on that now. And along with launching this, the state launched a training module. It's like a 20-hour training to actually take people who haven't done this work before, just might have some basic skills, and train them to be contact tracers. And we're developing our own internal training to complement that. And so the goal of this is to be able to really onboard people relatively quickly who have relatively little experience and create a workforce that can help us meet the demands. And so we can come back to the hotels later and the reopening plan. Let's see. I guess that might be my last contact tracing slide. I thought I had a partnership slide, but I mentioned before, we really are looking to some of the organizations in the county that are already bring some of the staff and experience that we need. And that's kind of the first set of partners we're engaging to do contact tracing expansion. Also, we're working kind of on a separate track to give guidance to businesses who don't necessarily want to join this effort, but want to figure out how they can support their workforce and address COVID in their workforce. And we put out some guidance before, but as people are coming back to work, we really need to lift up that aspect of things and support employers to manage COVID within their teams. And then the last piece is volunteers. And so, really since contact tracing kind of hit the news with COVID, which is maybe a month or 6 weeks ago, people have been just streaming, pouring into our inboxes with interest in volunteering. We have, I'll be honest, we have way more interest than we know what to do with. And it's wonderful for us to see that so many people want to help contribute to the response and find a way to partner. And we have, I think I heard mention that somebody had completed an application. There's been a few different portals where people can join the county and participate. I'm not familiar with that application, although there's a general volunteer application that may have been distributed. I will tell you that we are not onboarding volunteers to do contact tracing now. We are just getting to know the state data system. We're just implementing this plan for expansion, and we are not ready. We're not ready to bring volunteers on. And I think as this continues, there is going to be a role for volunteers, but it's going to be a big commitment, because if we invest in training somebody for 20 hours plus maybe 5 hours of county training, we're going to want, it's probably going to be, a certain number of hours a week, I don't know, 20, something like that. So it's going to be a pretty substantial commitment that we expect out of people. But we do want to find a way to incorporate volunteer interest, because we want to be able to channel all of the energy that people are bringing forward in the community to support this effort. So I want to pause there, because I know that this has been a really big interest, and maybe have a little discussion about that.
Well, so on that front, you mentioned the state program that you were not quite ready to jump into, but if someone wanted to do that 20 hours to prepare themselves for whatever you tack onto that, is that available? And if so, where is that available?
Sure. So I don't believe, so we're piloting now, which means we're able to use it, and we're training people every week, and they have 2 trainings a week. I believe they've only opened this to local health jurisdictions to actually train on the system for a number of different reasons. It's new to them as well, and they kind of want feedback from jurisdictions who are trying it out to see what they can do better. It may be true that that training is opened up down the road, and that people can sort of self-initiate and do that. But I don't believe that's the case right now. So I don't even know. I actually searched. CalConnect is the name of the platform. I don't even think they have like a public-facing website yet that sort of explains it. There might be, but I couldn't find it easily.
Huh. And do you know, is there technology being developed for this in terms of tracing people's contacts, and what kind of reception do you think that'll get?
Yeah, this is a question that we get a lot. We get it from the general public, media, and we also get it from software developers who have products. So this system that the state has developed is really about the contact tracer, where they can record information, where they can submit information, they can track their work. We can text. I think it has now a text, outgoing communication functions. We're hoping to be able to send letters through it, because sometimes we need to issue like an actual letter in certain situations. it does not, there's no client, there's no case or contact aspect to it. So there's no app that the case or contact installs like on their phone or anything like that. There are third-party technology tools that are out there that are with the goal of sort of people voluntarily including their information, like their COVID status, and that try to determine whether or not somebody, if you don't have COVID, if you're a close contact with somebody who is, and then report that information. We have not explored onboarding this, I think, for a couple of different key reasons. One is, although it's voluntary, I think we're a little hesitant to jump into a tool that is, where we are endorsing like a movement tracking tool. There's a lot of trust issues with health in the community and public health, and I think COVID has been a little bit politicized in a way that also contributes to that. And so we're very cautious as a department about doing anything that could potentially violate the trust of people that we need to work with to restrict the spread of COVID. So that's one aspect. The other is, frankly, I just think the jury's still out on these and whether they are effective at identifying people who are truly at risk of developing COVID or not, and whether the juice is worth the squeeze. So are we going to get such great additional information from that tool that we're going to better contain COVID? I'm not convinced that's true yet. You hear press about this use of these kinds of tools in like cities overseas, things like that. I urge caution in making the comparison between our setting and those settings, and also remember lots of other things were being done at the time that those interventions were deployed that may have been more important. Testing, traditional contact tracing, and mask use. So we're not, I think it's very interesting. I do follow it, but we're not anywhere close to deploying anything like that now.
Do you even think to make recommendations? There was a statement / question about a restaurant in San Francisco that's providing customers who do their takeout, who get their takeout, with information about who prepared their food, so that contact tracing, should it be needed, could be done. Is that something that Alameda County has even considered?
Yeah. So no, the short answer is no. I think we're still planning around when dining, outdoor dining and things like that are going to be opened up. And I guess for takeout it might apply, but I think first of all, it's not clear that that's a big source of transmission in our community. I mean, the cases, I have to be honest, it spreads indoors in crowded settings, in settings where people have COVID infection and are coughing, and or in crowded households where people have mild symptoms, congregate living settings. It will probably, it spreads in some workplaces where people can't socially distance. People are close together, they may not be wearing face coverings. That's an environment where it might spread. But spreading to consumers who use those businesses, that could happen. I don't think that's been documented in the same way, and we have to be on guard for it. So I think we would want to, focus our efforts in terms of collecting information or having the public take certain actions in areas where we know there's a prevention bang for the buck. There are settings where we do want to know who got exposed. Healthcare outbreaks are a good example. It really is important to know who is exposed and who is not, and follow up with those people. But a lot of those settings do keep records of who's moved through their business. The situation that we get asked about is like, well, what if it's a BART train? You find out that somebody was sick and they were on the BART, and there's no other way to identify the contacts. And so first the question is, how much spread is happening in that setting. And it's a little hard to know right now because BART's closed and a lot of subways have been closed. And so we can't draw on our lived experience yet. We kind of have to project. If certain measures are taken, they're keeping the trains less crowded, people are wearing masks, we actually think that the spread in those settings will be less. And if we had to, we could do a public notice, but we really find that, again, the benefit of doing a public notice in something like a bar or a restaurant has to be weighed against like the cost of causing undue concern and not really resulting in increased case detection. So I think all of these decisions about when information is collected or how what makes the most sense, again, it goes back to whether the juice is worth the squeeze. So anyway, so we don't do that. We're not advising restaurants to do that now, but there are settings where it is important to keep track of who's in and out of the place. And as more businesses increase, we might see more of that. I think personal grooming settings everybody's concerned about, like if you go to get your hair cut, maybe that's a setting where we want businesses to keep a little bit of a track of the clients. They probably have appointment records, but maybe they have drop-ins and people don't write their name down. So, maybe collecting better data around that would be helpful.
Mm-hmm. So what are some of the markers that Alameda County Health is looking for to move us to the next level of opening up? And how does that compare to some of the surrounding counties and what they're doing and lessons learned and what both locally and internationally?
Yeah, I mean, so this is our indicators slide, and it's generally in alignment with indicators that are used by other Bay Area counties and the state as well. But there's a lot of indicators out there, and there's definitely misalignment in places. So these are the things that we've been following in terms of making decisions about when to reopen. And we try not to set hard and fast thresholds either with the indicators or with the timeline, because we want to be able to weigh all the indicators together. And we also we don't want to back ourselves into a specific timeline, which we can't meet. So a really important one is cases, but as I said, that's a little subject to testing, and we've been increasing testing quite a bit. So also hospitalizations, whether hospitalizations are flat or decreasing. Generally flat at the moment, but we had a little bit of an increase last week. And I have to be careful not to look too closely at any given day. We really need to be looking at trends, right? For statisticians on the call, it can the data. There's a lot of noise in the data, and we really want to look at trends over time. So hospitalizations is a real important one, and then how well. This is a more. There's a few different things that go into this indicator, but basically, how well prepared our hospitals are to take a big increase in the number of patients, which is what we get concerned about with pandemic surges, like a surge of cases overwhelm our hospitals, all the beds would be filled with COVID patients, and people who have other conditions can't get in. So we really want to make sure our hospitals are prepared. We've done very well there, and we haven't had big burdens. So that we've 5 boxes is our way of saying we think we're in good shape. Testing capacity, we've ramped up quite a bit. I think it's actually up to 1,800 tests performed per day in Alameda County with a goal of 3,100. And then disease containment. We've done actually not a great job of really getting very high quality indicators of how well we are isolating cases and quarantining contacts. This is the thing where I think the Salesforce platform, Cal Connect, will help us because it's sort of baked into the platform, and where our existing data systems have kind of hurt us. But I would say my gestalt is we're doing okay. We could do better. And then the last box has to do with how well equipped hospitals in particular are with protective So these are the things that we really follow and we look for improvement on or stability on before we advance to the next stage of reopening. And really, cases and in particular hospitalizations are a big one, which we saw a jump with some recent loosening of social distancing that coincided with us kind of overtaking Santa Clara as the most impacted county. And so that's a very important one.
Are there any things on the horizon for either the county or the state with regard to the sequestration of people who might be coming? Like extend a conventioneers or some, gatherings that are large and that you might be on the lookout for?
Yeah, that's a great question. So because travel has been restricted, this hasn't been as much of an issue, and also congregate activities are restricted. So there aren't conferences happening, and so we're not, experiencing as much of that. And I know that other places around the world have implemented quarantine for travelers. I myself had to fly to the other side of the country in the middle of April, and I thought I was going to be asked to quarantine for 14 days at the other end, and it didn't happen, fortunately. But yes, I think that there will probably be ongoing voluntary quarantine of travelers. So we're not necessarily going to, within the United States, it's difficult. People come in from all directions. This is a big travel hub. We're probably not going to have the ability to track every single traveler who gets off an airplane, especially if they're coming from other parts of the United States, which may have different COVID policies. And so it's probably going to be more of a voluntary, or even driven by the businesses that might be hosting people, process, as opposed to an enforced quarantine of travelers. And it's just a bandwidth issue as much as anything.
So we had a couple of questions about testing and the best type of testing and antibody testing versus the swab testing. And this one I'm going to read directly because I'm not sure I totally know all the terminology, but one of the bottlenecks in testing seems to be frontline sampling. Is that accurate? And how does the Alameda County Public Health Department of Public Health help increase the amount of testing?
So there have been so many bottlenecks in testing, as has been in the news, and I think really particularly hampered the response early on, where we actually didn't know how widespread COVID was. In Alameda County, in retrospect, I think it was, we weren't missing a huge amount, we were missing some, but we didn't really know at the time. And then we got lucky because San Francisco and Santa Clara were being hit harder earlier, and we all went into shelter in place at the same time. So I think it didn't impact us as directly as it did some other places, the testing problems early on. But now, it remains a huge problem for getting testing deployed in all the places we want it. We have capacity in the county, but it's sometimes hard to match that capacity to where there is need. So now the state really wants a high level of testing going on in nursing homes. But they don't always have the ability to do their own testing, and matching their need with existing capacity has actually been a big coordination challenge. There have also been bottlenecks, just as, 1 week there's not enough swabs, the next week there's not enough media. We put, the fluid that you put the swab in to send it to the lab. And then the next week there's not enough masks for the healthcare providers or one facility has enough swabs and masks but not enough media, and the other facility has too much media. So we do have a county resource request process, so any provider can ask for these materials to support their testing. And then we have our own lab, which is small, but we're able to plug in that lab support in sort of high need areas, and we're trying to actually expand how much COVID testing we do. Our lab was one of the first labs in the country to start doing the CDC test, and so we have a lot of experience now. And then just having staff to be able to do it in a safe way is another bottleneck. And so we're also training staff in some settings. We're trying to stand up a training team for long-term care facilities in particular. They have medical providers, nurses who could do testing, but they just need to learn how to do the test. And so we're trying to kind of spread that knowledge. And then we actually are contracting with providers I think we released a request for proposals yesterday or today, countywide, to solicit providers to provide testing. We've kind of done it with some emergency contracts because it's an emergency, but we're trying to expand the number of contracted tests supported throughout the county. So those are the different ways we're doing it, and we've deployed testing in some impacted communities: West Oakland, East Oakland, Fruitvale. I think was through La Clinica, one of the federally qualified health centers in the county, was going to start testing maybe yesterday or today. So we're really focusing on some of those impacted zip codes and communities that I shared earlier.
So that's where you're putting your testing, but if anyone who's a resident of the county showed up at one of those testing sites, would they have the ability to be tested even if that isn't their neighborhood?
Yeah, no, I believe in most cases these are open to all comers. I can't promise that's true in every single case, but we do have a resource on our website. I can see if I can find it and share it, that has the list of our sponsored sites. And then, excuse me, it's not COVID, I don't think. That's why we're Zoom meeting, right?
Right.
So we have and then we have a longer list of other testing providers across the county. And there are a bunch, people who have healthcare providers who are sick. We really do encourage to use their healthcare providers. Many of them are set up to do testing. But in some communities, there are access issues. There are other issues with getting into a healthcare provider. So we've tried to create other opportunities. And we really wanted to make sure testing was deployed in places where there was a lot of known COVID. And so I don't want to give the impression that we're sort of favoring certain communities over others. We're really trying to direct it to where we see the need from the data. But yes, I think pretty much anybody can show up, and we're adding more as we go.
Gotcha. And so, because I know you have experience in this, how does the spread of COVID-19 compare to, particularly within this area, compared to other communicable diseases that you've seen come and go, whether it's measles or AIDS or whatever? How is it spreading? Does it spread disproportionately through the same types of populations that you've seen with COVID?
Yeah. So I think, there's a couple aspects to this, but one is communities that have for longstanding reasons, structural racism, social inequity, income inequality, have had seen other health disparities are, for many of the same reasons, it appears, experiencing disproportionate impacts of COVID. So vast majority of early in COVID, it was like people who traveled, cruise passengers, people who had been overseas, fairly affluent people being impacted. But with shelter in place, it's really moved to impact people who lived in households where there was a lot of people, or people who live in shelters, people who live in nursing homes, and people who have to work, like had to leave their house and work with other people during the shelter in place while I could work from home and do everything through my laptop. And so those things are impacted by, the economic circumstances of the people we're talking about. And again, I mean, just look at the numbers. In Alameda County, it's far more cases in Latinx communities than in other groups. And then in terms of who gets the worst outcomes, so our deaths are disproportionately in African Americans, and we don't fully understand why that is, but it may very well have to do with the fact that there are higher rates of medical comorbidities in those communities, which are there's a large literature on this, but those are for many of the reasons that I mentioned before. So we absolutely have seen COVID impact communities that are disproportionately impacted by other health issues, but not always for the same reasons. I mean, that HIV doesn't spread in crowded households. I came from our HIV program, and it's for different reasons, but if you kind of go upstream enough, you start to experience some of the same reasons: stigma, a healthcare system that has not always served those communities well, or built trust in those communities, and those are profound problems when you're trying to spread messages of prevention and health, and there are responsibility to try to unwind and address.
Gotcha. So quickly going back to the testing question, is it a recommendation of the county that everyone be tested even if you are asymptomatic, or are we taking resources from communities that actually need to be tested?
I'm pretty sure in our most recent health advisory about testing that we are still not recommending testing for asymptomatic persons who just want to know what their COVID situation is. And there's a couple reasons for that. One is we want to prioritize testing for people who have an exposure or are sick. And the other is that a single point in time test, the test that we recommend people use is a molecular test or PCR test, a test that looks for the viral genetic material, RNA. That's the test that we want to use to diagnose COVID. And if you've been exposed to COVID, you can get tested and it could be negative, but you still could get infected. There's this 14-day period after exposure where we know most people will get sick if they're going to get sick. If you get tested on day 3 and you're negative, that doesn't mean that you're off the hook. So that test may give misleading information if somebody's asymptomatic and they just want to find out. It's really about the exposure, and I think that should drive testing, particularly in people who don't have symptoms. So we are, I have to say, I mean, I really wanted to see the evidence first, but as did my colleagues. I don't make all the decisions here by any stretch, but but we really are advocating more testing in asymptomatic people, but only in these settings where there's exposure. I think that for people who aren't really exposed, it's not clear the benefit.
Gotcha. So then for our last question, do you see issues with different counties reopening at different rates, at different levels? We've got Alameda's in one position, Contra Costa in another, San Francisco, Napa is opening up considerably more than everyone else. Does that propose a problem from your perspective?
It's very complicated, very complicated. We've definitely moved slower for some of the reasons I've shared. And the Bay Area as a whole has moved slower. But the big population centers in California have had to move slower than the counties that are less densely populated because they have more COVID. It's been really complicated because of the federal and state politics and public discussion around it. It's become very politicized. The state has kind of wanted it both ways. They wanted to lock down, but then they wanted to reopen, but they want us to move slowly, but they want us to, and then some counties, the political imperative to reopen is stronger. Here, I think the public has been more, as a whole, supportive of this, and we've been able to be more cautious. But it's very difficult when we want people to stay at home and we want people to, just go to the grocery store and then go home and cook. But you can drive to Solano County and go to the restaurant and they're open for business. And so, I think we do pay attention to that when we make our decisions, but we also try to make our decisions based on the data here in Alameda County, because we have a responsibility to the broader community to protect people from COVID and to slow the spread. And we do have to balance that against what's going on in other counties. And I admit, against the economic imperatives and against the personal and social imperatives to get people back to something like normal life. So it's a high wire act, and the fact that it's different in different counties does not make it easier. But we like most folks, we want to reopen more. We just want to do it in as safe a way as possible. We want to be ready, because
Right.
the more people mix, I think maybe summertime we'll get a lull, but the more people mix, the more COVID we're going to see, at least in the short term.
Great. Well, thank you. Dan, I'm punting back to you.
No worries. Thanks, Jillian. Really appreciate it. Dr. Moss, thank you so much for spending your time with us tonight.
Yeah.
I'm sure you're on these Zoom meetings more than you can ever ask
A lot of Zoom. I got to work on my background. It's pretty boring.
We can send you a few Rotary ones if you're interested.
Yeah, I mix it up. I'll mix it up.
But again, I do want to thank you. As a token of our appreciation, we'll be donating to the polio mission in your name, and really want to say just thank you for everything you're doing for us, for Alameda County, and really hope that everything continues in a positive manner in the way it's going.
Well, as an infectious disease physician, I'm honored by that, and I so respect what Rotary has done with polio, and I think that it's a hugely important commitment, and people don't see much polio in America these days. It's one of these things where when people talk about vaccines, man, what a terrible disease, and what a good thing to be committed to eradicating. So thank you. I'm honored, and it was great to be here, and maybe we'll get a chance to do it again someday. And I do want people to know, we didn't talk about this much, but we want to find, if it's not contact tracing, we want to find other ways to channel and get some of that volunteer energy. Maybe it's providing support for people in isolation or quarantine. We do really want to find a way for people to serve. So I'll leave you with that.
Rotary.